When placing an immediate implant, you would really have to jump through hoops to try to get primary closure over the implant. So most of the time, immediate implants are placed in a single-staged approach with a healing abutment. Now, some may argue that you want to place an immediate provisional crown or a custom healing abutment in order to seal the gap between the soft tissue and abutment, as well as to provide support for the particular bone grafts. But in most practices, I'm putting on a stock healing abutment for practical reasons. So today I want to show you a suturing technique that works for me in minimizing the gap and stabilizing the flap. The implant system that I use is Neodent, and because this implant uses platform switched and Morse tapered internal connections, it is designed to have the implant platform placed subcrustally. So once the healing abutment is placed, there's going to be a fair amount of bone placed above the implant platform. So I make sure to pack the bone really well. Now, if I'm placing an immediate implant in a single rooted teeth, there's going to be an issue at the proximity of the implant surface to the buccal or the lingual bone. So therefore, it's difficult to get all of the bone grafts to the apical portion of the extraction socket. So I'll use a narrow instrument such as an Orban knife or a periodontal probe to pack the bone more apically. After I'm satisfied with the condensation of the bone in the apical portion, I'll go back and I'll make sure that the coronal portion is well packed and condensed with bone. And now I'm ready for the membrane placement. Now that the membrane is placed, we're ready to suture the flaps. Here I'm using a variation of a sling suture. Now I'm starting on the buccal flap, and as I'm going to grab the lingual flap, I'm going towards the mid portion of the flap, almost directly lingual to the implant body. And then I'm going to come back around and grab the buccal flap here. And the silicone tissue on this model is not as pliable as the real gingiva, so I'm having to manipulate this a little bit. And with the second pass, I'm going back through to the lingual flap, almost at the same exact position that I came through the first time. This actually goes a lot smoother in a real patient. When I'm using a monofilament suture, such as this polyglycolide suture that I'm using, I like to throw in an extra knot right at the end, just to make sure that I have good knot security. Now you can see how secure the flaps are, and the flap margins are much more closely adapted. In patients with normal healing response, with the epithelium migrating about 0.5 to 1 millimeter a day, you should get pretty good closure in a matter of days.